Chapter 17, Using the DSM-5. DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. It is used by numerous agencies and services besides mental health. The first DSM was published in 1952 to try to standardize psychiatric diagnoses and the language used to describe them. We are at now on DSM-5. And as a matter of fact, your textbook, even the 5th edition, is still covering it as DSM-4. Here I am presenting DSM-5, which has been in effect for about 2 years now, and you really need to know DSM-5. So pay most attention to this PowerPoint chapter. Diagnosing for certificate level staff is outside of the scope of your competence. Generally, it takes a master's degree person to do the diagnosing. Diagnosing is the language of insurance and funding sources. You do need to be familiar with this common language and understand the meaning of the various terms. The agency that you work for will have a DSM book available. You generally do not need to purchase this book. Use the handouts I have provided in the handouts folder in the file menu, and be sure to review the handouts prior to your quiz and your assessment write-up assignment. Most people seeking services in human service agencies are not mentally ill. The DSM is based on a medical model which treats the individual as sick, which can subtly diminish the person. Remember that others may see the diagnosis. The clients themselves, have a right to know their diagnosis and who will see it. Do not take cultural differences to mean that a person is mentally ill. So use caution when discussing actual diagnoses. DSM-5 is ordered in the book. Similar disorders are in adjacent chapters. It is, of course, published by the American Psychiatric Association, and they do have supplemental materials available online. The ICD numerical code that you will see are included to bring the diagnoses into line even internationally. So this is an international language. ICD stands for the International Classification of Diseases. And for that classification, ICD, we are on version 10 currently. Again, the DSM is organized by chapters. So if the person complains of hearing voices, you would turn to the chapter titled Schizophrenia Spectrum and Other Psychotic Disorders. And then each disorder has a list of criteria used to make the diagnosis. So here are the disorders organized. These are the chapters that are in the DSM-5. Neurodevelopmental, the very first chapter, refers to intelligence, learning, communication problems, motor issues, ADHD, and autism spectrum disorder. Disruptive disorders include oppositional defiant, intermittent explosive disorder, impulse control, and conduct disorders. Neurocognitive disorders include delirium, Alzheimer's, stroke, and Parkinson's, for example. Personality disorders are organized by cluster. Cluster A includes paranoid personality, schizoid, and schizotypical personality disorders. Cluster B includes antisocial, borderline, histrionic, and narcissistic disorders. Cluster C includes avoidant, dependent, obsessive-compulsive disorders. Take a look at the handouts under the File menu on the left-hand navigational tool. There are several DSM handouts. You will need to be familiar with all of them. For your assessment write-up, you will not need to write out the diagnosis with the number. Remember, that is outside of your scope of practice. Your textbook, for example, as I mentioned earlier, is still covering DSM-4 if you look in Appendix G. I am teaching you DSM-5 because that's what's currently in use. There are times when people seek help, but they do not have a DSM diagnosis. In this case, then, you would turn to the chapter titled Other Conditions That May Be a Focus of Clinical Attention. Here you will find normal responses to life changes. For example, other conditions that may be a focus of clinical attention include divorce, death of a loved one, stress related to a health condition, and others. Sometimes when the diagnosis and the various criteria does not quite fit, you may see a diagnosis that says other specified disorders. So be sure to look at that, which gives you options which might fit better. However, if none of the criteria seem to fit, we might use the term unspecified disorders. So, for example, we know the person appears to be depressed, and the person meets some of the criteria but not all of it, so we would have unspecified depressive disorder. This section is at the end of every chapter, and it's used when we know the symptoms belong in a certain category of disorders, but the person does not entirely meet all of the criteria. Now, substance use disorder criteria and diagnosis. An example is F11.20. Remember, that's the ICD code. Opiate use disorder, severe, in early remission. So the number goes first, then the severity, and you'll learn about that in a minute, and then what's called the specifier. The specifier usually are things like in remission, in partial remission, in early remission, or, for example, in a controlled environment. For example, the client has been in remission, but he or she has also been in a controlled environment. For example, the client is sober because they are in jail. So be sure to look at the handouts on the criteria for substance use disorder worksheet and definitions, because many of you are going to become certified alcohol and drug counselors. This is the one chapter in the DSM-5 that you really want to be super oriented to. Now, there are 11 substances. This year in DSM-5, cannabis withdrawal was added in this version. Caffeine use disorder and caffeine withdrawal was also added into the DSM-5. Amphetamine substance includes methamphetamine. Opiates. Can you name some of the opiates that would be included as an opiate use disorder? Well, of course, you would have opiate meaning heroin, opiate meaning OxyContin, opiate meaning Dilaudid, and various other opiate use disorder. It would all those different drugs would be classified under opiate use disorder. What are some sedatives, hypnotics, or anxiolytics? Anxiolytics? Well, those are benzodiazepines like Valium, Librium, Ativan. So if your client has a anxiolytic use disorder, they're using Ativan to get high, to change their mood, then that would be the diagnosis. In diagnosing, we use each substance is coded separately. Now, if they're using both, let's say, Valium and Librium as an anxiolytic, you don't code 2 anxiolytic diagnoses. You only have 1. Okay, so if they're using alcohol and anxiolytic medications inappropriately, then you would code 2 diagnoses. So, for example, you can also be different severity in the different substances. So you may have a severe cocaine use disorder and a mild in cannabis use disorder. The order for recording the different diagnoses and the different substances does not really matter in this case. Just be sure to code all that apply. A very thorough clinician will record nicotine and caffeine as well as if the client meets the diagnosis. That tells me a clinician is very thorough, that they even asked about nicotine, smoking, vaping, etc., and their client's caffeine use. Now, there's 11 criteria in order to meet the substance use disorder. But first off, in order to meet a substance use disorder, there must be a maladaptive pattern of use that causes impairment in life domains or distress in the client. And that pattern must have existed for a minimum of 12 months straight. These are the 11 criteria that have to be present. So, if your client has been drinking due to the death of their mother 6 months ago, is this an alcohol use disorder? The answer would be no, because it has not been going on for more than 12 months. Instead, consider other condition of clinical attention like bereavement that includes excessive alcohol use. So again, in order to even get a substance use disorder, you need to have used the chemical, the substance, in a maladaptive, problematic way for 12 months or more. And then you count up the number of criteria that the client meets in order to come up with the severity. So if the client has of the 11 symptoms, remember, if the client has 2 or 3 of them checkmarked, they would be mild on that substance. If they have 4 or 5 symptoms marked yes, then they would be moderate for that substance. And if they have 6 or more of the 11 checked off as yes, they would be rated as severe use disorder. So in fact, when you look at the handout, you are go ahead and you're going to dive in. You would have one of those forms per substance, and you would be looking for how many of the symptoms the client has. In the assessment interview, it goes something like this. So tell me about your alcohol use disorder. Let's say in the past 30 days, what has your alcohol use been like? I wouldn't say disorder. What has your alcohol use been like? And the client will tell you and describe it and so forth. As the client is telling you, you could be checking off some of the symptoms. Or another way is to point blank ask the client, I'm wondering, have you ever drank more than you intended to? Have you ever tried to quit drinking and have been unable to stop, either once you started drinking, let's say, for a party? So again, you can ask the specific question, yes or no, or you can gather information without asking specifically the client. And remember, even though in my example I asked for the past 30 days, that gives me a more recent history. But again, the time period that you're looking on is the past 12 months. So you could in fact ask the client, during the past 12 months or the past year, how has your drinking been? Okay, and then you would tie it to the time frame. All right, Chapter 18, the Mental Status Exam, also known as the MSE. There is a handout also in the file menu that has definitions for MSE. You will not be doing a formal MSE, but rather this topic is presented for you to use the terms and your observations in your progress notes or in your impressions section of the assessment write-up. You are observing the client. These are not questions that you ask the client. These are mental status indicators that you are observing, and you are observing the client verbally or non-verbally. So, for example, what to observe? General appearance. What does the client look like? How well do they take care of themselves, their hygiene and their dress? Note their posture. Note their attitude and motor activity during the session. Look at how the person speaks. Is it pressured, emotional, or impoverished? Does the person make up words? So they may have fluent or bizarre, nonsensical speech. Again, these are not things that you ask about, but you observe. You may also observe emotions. And so you're going to notice, what is the client mood during this session? Are they happy, anxious, or euphoric? Is there a flow of moods during this session? Do you see things that are vegetative signs of depression? So listen for complaints about sleep problems, falling asleep, or staying asleep. Cognitive functioning is important to observe. Remember, cognitive functioning can also be related to drug use. Memory problems have been tied to chronic marijuana use or chronic inhalant use, for example. The client may not even be aware that their cognitive functioning is different than other people's. These are things that you are observing. There are specific terms. This is clinical language that you can use in your assessment write-up. So if you talk about the client's thought content, we all know that you are talking about how the clients think. If you are talking about thought process, what you're looking at is how the thoughts flow together and relate to one another. Do they seem to switch topics and somehow you're unable to connect the dots in the conversation? That would be thought processing. You will need to ask detailed questions about suicidal attempts in the past, suicidal thinking in the past, even without an attempt, or suicidal thinking currently. Ask for details. Does the client have thoughts? Is the client actually making plans? What are those plans? How does the client have the plan all developed? Okay, if you become concerned about the client during the assessment session, you need to stop doing the assessment and move to safety planning and crisis work with the client. Your textbook, at least the 5th edition, and this part is new for the 5th edition, has a really great Appendix H covering the case manager's toolbox and assessing lethality and suicide assessment. This is on pages 512 to 514. Remember, harm to self and harm to others are two of the exceptions to confidentiality. So you can and must seek help for the client. You can break confidentiality and certainly do not let the client leave the premises without a secure safety plan in place. If it actually happens that the client runs away or leaves, what you would do, you would not tackle them and keep them there, but indeed what you would do is call a psychiatric team or call a law enforcement to do wellness checks and or to assess for suicide or homicide. In homicide, of course, you have your TerraSoft obligations as well. What more to observe? Insight and judgment. Observing accuracy of the client's report. Sometimes you will notice discrepancies in, let's say, the police report that you got and the client's report of what they're telling you happened. Again, you can point out those discrepancies to get the client's read on that, or you can just observe it and note it in your report. How about the environment? If this is like if you go into a home visit, are there strange things in the home? Do not mistake poverty, however, for an inappropriate environment. Be sure of what you are seeing is really a manifestation of mental illness and not some other way of keeping things that way. Here are some common everyday terms. So sometimes we say things like, she's so confused. But don't use confused and obsessed in your clinical report if you're really talking about the everyday definition. Again, everyday language, it has no place in a clinical report. Okay, now let's talk a little bit about the ASAM criteria and level of care. ASAM stands for American Society of Addiction Medicine, and the levels of care generally, level 1 and level 2 is outpatient treatment. Level 3 is residential treatment, and level 4 is medical or hospital. So the higher the level of care, the more intensive or restrictive is that level of care. Level of care, the top level is level 4. Okay, so how do you decide if the patient in front of you really needs outpatient or residential treatment? Well, we use what is called the ASAM criteria as the decision tree to make level of care determinations. A certified alcohol and drug counselor staff member can make ASAM level of care determinations. You do not need to be a licensed clinician or a master's degree person to understand this. An example. So you have been working with your client for several months, but they don't seem to be getting any better. You decide to call them in for an individual session and ask them more about their drug use. And the client breaks down and lets you know that they have begun to shoot up heroin and are afraid of overdosing. You are the one who decides when is the time to make the referral to residential treatment. And you do this by using the ASAM rating scale. The ASAM criteria is based upon 6 dimensions. And those dimensions, dimension 1 is acute intoxication. That means they're going to go into withdrawal. Number 2 is a biomedical conditions and complications. So sometimes, for example, alcoholics may have a high withdrawal potential, and then they also are prone to seizures. So that would be a high score on level dimension number 2. Emotional, behavioral, and cognitive complications, co-occurring disorders goes in dimension 3. Readiness to change or the client's motivation is in dimension 4. Relapse, continued use, or continued problem potential is in dimension 5. And living and recovery environment is in dimension 6. The most immediate important dimensions are dimension number 1 and dimension number 6. A high rating on these 2 dimensions will indicate probably an immediate placement into residential level of care referral. So here is what the ASAM sample rating scale looks like. The 6 dimensions are outlined along a continuum of severity from no problem, that meaning 0, to a severe level of problem in that dimension, which is scored at a 4. And you would go through and check the different boxes that apply for that client. Sorry, I'm kind of trying to mark the bubbles here for you so you can see how it goes. And then you would go through and score, so to speak, loosely look at the ASAM. Now, of course, if the client has zeros all the way down, they wouldn't need any treatment at all. And so your level 2 and 3 here generally mean outpatient, okay? And then levels 3 and of course level 4 begins to mean residential treatment as a level of care. Okay. More specifically then, the levels of care for treatment are outlined here. There are handouts on the ASAM in your handouts menu under files. Level 1 is outpatient treatment. Level 1 treatment is from 1 hour per week up to 9 hours per week. Level 2.1 is called intensive outpatient treatment, IOT, which is from 9 hours to 19 hours per week. Level 2.5 is called partial hospitalization program, PHP, which is over 19 hours per week. They are at the program. Level 3.1, again, 3 is residential. So we're talking about residential treatment, low level intensity, 20 hours per week of services with at least 5 hours per week of clinical care. Level 3.3 is residential treatment, but it includes specialty populations such as co-occurring disorders, substance use disorder and mental health diagnosis, or perhaps traumatic brain injury, TBI, services. Level 3.5 is residential treatment, high level intensity, and more clinical hours per week. Level 3.7 and level 4, which is the highest, is medically monitored and then medically managed clinical program, meaning the client needs to be in a skilled nursing facility or a hospital. The next steps, you will have the assessment write-up, which is due on April 5th, 2020, which is worth 25 points. Submit your assessment write-up in the module for the upload. Also, before April 5th, you have quiz number 6, which covers chapters 16, 17, and 18. After that, you have spring break. Have a good time.